Can you hear me? Am I loud and clear?
As in, cool.
Am I loud and clear to everybody?
Yes.
That's brilliant. You can just give me a heads up as to when to start if you want me to start now, or should we wait for 5 more minutes,
definitely.
or should we
just
start?
5 more minutes and we'll start, and I'll give you the heads up.
Yeah, don't worry about it. That's brilliant.
All right, thank you so much.
Thanks.
So we'll start at 8:35. We'll let the audience join until then. Dr. Saad, as in, would you be putting it as like this, or like would you be putting it as a slideshow for the?
I'll be putting it out as a slideshow. I'll just start the slideshow when everyone's there.
Yeah, I will start with that. I'll let you know.
No, don't worry.
So how long is your presentation?
So essentially, I've done a similar presentation like this where Rajeshwari was present. This took like quite some time, but I don't want to, since I want to show a couple of PLAB2 videos as well, probably just one or two. So I probably would want to show 2 videos regarding PLAB2. So what I would, so I think 1 hour for the total presentation, I think would be adequate. So I think based on what Rajeshwari told me when she talked to you guys yesterday, you wanted me to explain a little bit about the introduction of it. So I think that'll take 10 minutes. So the actual PLAB1 questions where I'm explaining the topic and asking a couple of questions, I don't want that to exceed maybe perhaps 30 to 40 minutes. So if you could just stop me at the 9:20 mark with the slides, just give me a heads up at 9:20 so we can show 1 or 2 videos with PLAB2, or whenever, if you feel like that's earlier, so we can show those 1 or 2 videos, and then whoever wants to ask a question is more than welcome to go ahead.
So what do your videos entail exactly?
So my video itself is, I've sent the links, it's just regarding, so the slides that I've prepared are mostly to do with PLAB1 related questions. The PLAB2 simulation, I couldn't find any of my colleagues on such short notice to do consult with to show everyone how that would be. And I think online it'd be a little weird as well. So I thought it's better to show lab to related videos because it's a more practical approach, where you're sitting in front of the patient. So again, I want to show two videos, each probably 8 minutes, but we can stop with the first video as well if we don't have time.
Yeah, I'd
And
request you to keep the videos to a minimum, since like we would like to interact with you directly, right? Since we have somebody who
that's
has
perfect.
like
That's
expert
perfect. That's perfect.
information on the topic. So like
That's perfect.
videos
That's
will
perfect.
keep to a minimum. Yeah.
Right. So what I'll do is I'll just show one video. It's like an 8 minute video regarding how exactly a PLAB 2 consult would go. We can start question and answers after that. If
All
we
right.
have time, or I could just,
Was it the example station one? Would
it
you
was
want
the
to show
chest
that
pain
one?
station.
Yeah,
So that
assessing
would
the
be my
chest pain, right?
priority. So to show
Okay, yeah,
something like
cool,
that.
good enough. I'll show
If we
that.
have time, the other video, but otherwise, because I feel like the other video is a little interesting just because it's, I mean, I'll let you know which one to play. I just figured chest pain because we're doing
Perfect,
like
perfect.
cardiovascular
We'll go
related
with the
things.
flow. We'll go with the flow.
Yeah, whatever
And
is fine.
towards the end of the presentation, we'll entertain questions from the audience, since they'll be
Yeah,
having queries. So we'll go with that
absolutely.
towards the
Look,
end.
if somebody wants to ask me a question in the middle also, that's more than okay. I think that would disrupt the entire time
Yeah, which
process.
is
I have no
why
problem.
we'll go
Yeah,
with questions towards the end,
no
since
problem.
it
No
will
problem.
disrupt
That's
your
fine.
flow of thought.
That's fine. That's fine. That's not an issue. Just the time, I guess. If you guys,
Right.
I'm not at a shortage of time, but I figure you guys want to wrap it up quickly. So whatever you guys are okay with, I don't have an issue.
Yeah. All right. Thank you. We'll start in a minute, sir.
I think I just have a request if someone could keep an eye on the text box because I can't see it since I'm sharing my screen. So if
Yeah,
anything pops up,
don't
if you
worry
could just
about
let me
that.
know.
We'll handle that. All right. Good evening, everybody. Welcome to PLABit. Today we have with us Dr. Saad Jamal, and I would like to welcome him to and thank him for sparing his valuable time with us to share his insights on this examination. I'm sure a lot of you are wondering what PLAB is, what country is it for, who should give it, when should it be given. So I'm sure Sir will cover all your doubts and queries. He has prepared a very beautiful presentation for us today. So I hope you all can stay till the end of the meeting to gain proper insight into this examination. We will entertain all your queries in the chat box. So spam us with your questions as much as you want to. We will take them up towards the end of the presentation. And I would like to give a huge round of applause. I would like you all to appreciate the IMA team for putting this together. We have a lot of IMA members on the platform today. Today we have with us Rajeshwari and Khushi, who are both important members of our IMA state team. Rajeshwari is a part of the academics team and Khushi is a part of the PRC team. I would like to acknowledge our 3 core members as well. One second, there is some net issue. I'm really sorry for that. I would like to acknowledge Dr. Dhiren Kavalaria, sir. He is the chairman of Indian Medical Association. And in our team, we also have 3 MSN members, or the Medical Student Network members. We have Dr. Rishi Dhamecha. He's the state convener of IMA MSN Maharashtra. We have Malvika Dhirwani, who's the state co-convener. And we have Kunal Shah, who's the general secretary. So with that, I would like to call upon Rajeshwari Bal to introduce sir and to go ahead with the presentation. You have the stage, Rajeshwari.
Okay, good evening, everybody. So I hope I'm loud and audible to you. So starting with today's session, we have Dr. Saad Jamal with us, who has passed out from Rajeshwari College and has cleared PLAB 1 and 2, and right now is GMC registered as well. So thank you so much, Dr. Saad, for giving us this opportunity to clear our doubts and giving us, we are very happy to give you this platform to help all the students you can. So over to you, sir. Can we just begin with what exactly is the introduction to PLAB and everything?
Yeah, absolutely. Thank you so much to the IMA team. You guys have been absolutely brilliant. And, huge props to you for putting this up. So I think we'll just get started right away. Hi, everyone. I am Saad, and I am a GMC registered doctor. I got done with my internship in 2020. I gave my PLAB 1 in the same year in 2020 itself, towards the end of 2020. Supposed to give my PLAB 2 in 2021, but I had it postponed because of COVID, and I gave it earlier this year.
college पर्यंत जा बाबा.
I think somebody is.
I request everybody to stay on mute.
We'll clear it out. Sorry.
Yeah, no, please. That's all right. So I cleared my PLAB 2 earlier on this year. So I just thought, what better way to tell everyone, because I feel like there is a lack of support regarding PLAB out there. So let's get started without any delays right away. So I've divided this presentation into 3 parts. The first part, we will talk exactly about what exactly the PLAB is, right? The parts of the PLAB and what you would require for the PLAB. I understand it comes with a lot of questions, so you can put up your questions in the chat box and hopefully we'll be able to answer them whenever. The second part is where we talk about everything related to do with the PLAB, the costs of it. I understand that's an issue that a lot of people need to think about, what exactly the different steps involved. And the third part will be regarding the PLAB 1 questions and how exactly they are. So PLAB 1 questions are relatively easy. It's not a cakewalk, I would say, but it is relatively easy if you put in the effort. It's not a very labor-intensive exam. And then we also have a video regarding how exactly a PLAB 2 consult would go. I focus more about PLAB 1 in this presentation because I would prefer all of you to not focus on PLAB 2 until you absolutely have to. And that's a different topic altogether. So let's get started right away. So what exactly is PLAB? So the PLAB stands for the Professional and Linguistics Assessment Board, where they test your professional knowledge as well as they test your language skills. Earlier on, you did not require a language exam to write the PLAB because the language exam was a part of the PLAB. Right, so this was around 20 years ago, 20, 30 years ago, probably. But now the PLAB has been divided into 2 parts, the PLAB 1 and the PLAB 2. The PLAB 1 is an MCQ-based paper, right? It has 180 questions to be solved in 180 minutes. That is 3 hours, right? Most of these are practical-oriented questions. And essentially what you would do as a junior doctor when you encounter such patients or when you see certain test results and all of that. The PLAB 2 is a little bit more complicated in the sense that you're dealing with a patient in front of you. And you have to, and there are different kinds of scenarios that you will have to deal with. Either you'll have to diagnose a patient, or you'll have to tell a patient, you'll have to break some bad news to a patient, or you will have to interpret certain test results. You might have to teach a couple of students. So there are a lot of scenarios like that in PLAB too. So to write the PLAB 1 as well as to book the PLAB 1 even, you will need to pass a language exam, right? So there are 2 language exams you can write for this, either the IELTS or the OET, right? The IELTS is cheaper than the OET, but I would always advise somebody to go for the OET because it's a lot more easier. And please remember that the PLAB is a licensing exam. It doesn't guarantee USMLE. You might pass it, but it does not guarantee you a match at all, right? So the PLAB is a licensing exam, but the chance of getting a job nowadays is pretty high, I would say. So I would still say that the chance of matching or getting into a job or getting into trading is still higher than the MLE. Obviously, the MLE is a great system. It's very financially rewarding as well. Everything has its pros and cons, but that's a discussion for another day, right? So I'm just wondering, can everyone see my cursor on the screen?
Yes, we can.
Yes,
All
everybody
right.
can see it.
Brilliant. So essentially, this is what a timeline for the PLAB would look like. We need to remember that after medical school, UK graduates don't do 1 year of internship, they do 2 years of internship. We call that internship foundation year. So there's foundation year 1 and foundation year 2. So essentially, someone who passes medical school in the UK would start at the beginning of this timeline, right? So they would do 1 year of foundation year 1 and 1 year of foundation year 2, right? And then once that is done, they can go into core training, which we can equate to PG, right? So that's usually 3 years. And then you're going to specialty training, which is usually super specialty. And that is usually another 3 to 6 years, right? However, since we've already completed 1 year of internship, or we will be completing 1 year of internship, the UK does recognize that 1 year of internship. So we don't need to repeat the 2 years. We just need to do the second year of internship. It's not necessary that you actually have to join a program of internship. What you can do is you can just work a job in the UK at a particular level. So for example, in India, you have a lot of junior resident jobs available in hospitals. So a job similar to that in the UK, and you can get your form signed stating that you are equivalent to somebody who has completed his second year of internship. And you don't need to do a whole year for this. You can finish it off in 6 months. Followed by this, to enter a specialty, it's very similar to the matching system in the US. You apply, first of all, you submit your CV, they shortlist your CV, and if you're shortlisted, you go in for an interview, and then you go into training, that is core training. And to go into specialty training, you need a particular membership exam, such as MRCP or something of the sort, MRCP or MRCS or anything of the sort. Can I just ask if I'm clear at this point of time regarding just a summary of everything? I understand it's a little confusing, but I feel like this is more a topic that you're going to understand by asking questions about. So probably we can discuss this later, but am I clear regarding the timeline? Would that be, if you want, you can screenshot this, take it down so we can discuss it later. So can I just ask if everybody's clear about the timeline, or does anybody want me to repeat this at all?
I think there is one person, or I think 2 or 3 of them said.
Hello?
Hello, sir. There are people asking you what is MRCP.
Right. So what I would say is, so usually an exam in India for PG and all of that, right? We have certain exams. That is, only if you pass that exam, right, you will end up with a PG degree. So in UK, think about it this way. So MRCP is a specialty exam, right? Which means, so think about it this way. I join internal medicine training, right? And I finish internal medicine training, right? So in the UK, there are no exams for post-graduation, right? Like just in that 3-year training program, there are no exams that I have to give. I have a list of boxes that I need to check. But if I need to jump from my internal medicine training to a super specialty such as cardiology, I need an exam like MRCP. Like, for example, to enter at this particular stage, I need the PLAB, right? So to enter at this particular stage, I will need the MRCP just before my super specialty, right? So MRCP is a membership exam. It's a highly specialized exam, right? So it has 3 parts again. So for example, if you're in medicine, you'll have to give the MRCP. If you're in surgery, you'll have to give the MRCS. If you're in something called, if you're in something like pediatrics, I think you will have to give MRCPs. So there are different membership exams for each specialty like that, right? So you can even give the MRCP now, to be honest, you know, I mean, straight after internship, that's not a problem at all. Thing is, it's a little difficult. And I just, all right, that's fine. So yeah, so that's what MRCP is. Think of it as an exam that you give after finishing off your PG, right? But you need this exam to actually apply to even super specialty, right? It's not a competitive exam. There are no ranks. You just need to pass it, which is the same for PLAB. You are not competing with anybody else at all. You just need to pass the exam, right? So the PLAB allows me to enter, say, PG. The MRCP will allow me to enter super specialty. Can I ask if I'm clear regarding that? Or are there any other questions at all? Yeah, so I think if there are any other questions, you can put them in the end and I'll be more than happy to answer them. So again, this is a better representation, right? I know these letters can be a little confusing, so let me just simplify it for you. So this is something, this is a flowchart about how a UK graduate would look at the system. So they do med school, and then they do 2 years of internship, which is foundation year 1 and foundation year 2. You don't have to do 2 years of internship. You just have to do the second year, or you can work in a job for about 6 months and prove to the people that you're equivalent to someone who's done their second year of internship. So there's like a checkbox list that you have, and you can get that form signed by your lead consultant, right? So let's look at only the first line here, right? So core training, if I was to equate it to Indian terms, means PG. Specialty training means it is super specialty, right? So core training is usually, or PG is usually 3 years, and the super specialty itself can be anywhere from 3 to 5 years, right? And once you complete super specialty, you get something called a CCT, which is a certificate. It's called the Certificate of Completion of Core Training, right? And then you become a consultant. And that's the end stage. That is when you are truly the lead person in your specialty, and you make the decisions and nobody else second guesses you. So can I ask if everybody's got that?
Yes, sir.
That's brilliant. So I've got a question saying that, okay, we'll answer these questions later on if that's all right. Because I just don't want to be at a shortage of time, right? So we'll come back to the slide later as well. Don't worry about it too much. Right, so this is a very nice graphic that I found online on a website called the Savvy IMG, which has a lot of resources for international graduates who want to study in the UK and train in the UK, right, about the cost. So if you can just screenshot this, that would be great. It'll help you definitely understand. When they say maximum spend of £9,000, keep in mind that it does not go to £9,000 at all. Like, I would say, regardless of how much you end up spending, the minimum spend also does not really go to £5,000. I would say living, even while going to the UK for PLAB 2, living comfortably, I would say maximum I would have spent for my entire journey would be anywhere between £3,000 to £4,000 probably. Again, I have to calculate it, but please keep in mind that this is a very wide range and depends on a lot of things, but it's good to have an idea. Yeah, so can I ask if, yeah, we will make the presentation available to you. So what I will do is I will just, yes. So getting back to the basics, yeah. Of The ECG, right? So what we'll be learning over here is we'll be learning regarding ECGs. We will be learning about how to tell if somebody is having a myocardial infarction on an ECG, right? Which is very important because in the UK, as a junior doctor, you don't need to know everything, right? However, you do need to know about how to identify an emergency, and you need to know how to treat the emergency. If you miss out certain moderate conditions such as musculoskeletal chest pain or any other cause of chest pain which is not as serious, that's fine. But if you miss out something that could kill the patient, then you're at fault, right? They don't expect you to know everything that's complex. They don't expect you to know anything at all. You need to be able to tell that the person is having a heart attack and be able to treat that, right? So just to have the basics of an ECG, you don't really need to know what all of these waves are for. I just put it up there just to show you how the ECG unit looks like. So on an ECG, you have the P wave, which is the first wave. You have the Q wave over here. Now it's not dipping down, but this should dip down, and this is called the Q wave, right? The R wave is the tall thing right here, the upwards deflection. The S wave is the negative deflection over here, or the downwards deflection. And the T wave is the last unit of the ECG, or the last positive bump right here. So you have the P wave, right? The Q wave, which should be a tiny, it's not shown in this ECG, but it should be a tiny little deflection over here. The R wave, which points up all the way, the S wave, which again is a negative or the downwards deflection, and a T wave, which is a positive deflection. Now, there is only one thing you need to look out for, right? Since this is the S wave and since this is the T wave, the line joining the two is called the ST segment. Just remember that, and remember that this is a T wave right here, and the T wave is a positive deflection. That's all you need to remember. Everything regarding atrial depolarization, ventricular depolarization, I'm sure all of you have already studied it, right? I don't need to talk about that, and that's not something that you will remember, right? So we look at a better image of an ECG as well. So when talking about PLAB itself, right, the questions are a little tricky. That's the thing. Because you have 180 questions in 180 minutes, so you get a minute per question essentially, right? There are a lot of questions which you'll be able to solve in 20 seconds, but some questions require a lot of thinking, especially the ECG ones, right? It requires, and especially because most of the time it's a black and white paper, so although it'll be printed very clearly, it does take a little bit of time to identify, right? So PLAB questions are very tricky in the sense that they might, at the end of the question, they might ask you, there's a very different approach if they ask you what is the most initial step to be done and what's the most definitive step to be done. So let me explain with an example. You are a doctor in the casualty ward, right? Or in the casualty. A patient walks in, right? And starts having a seizure. Okay. There are two different things that you will end up doing. You will either, there's one thing that you do initially, and there's one thing which is the definitive management, right? So the definitive management that I'm going to do is I'm going to check if there's any lorazepam, that is anti-seizure medication, and I'm going to give the anti-seizure medication to the patient. But that's not the first thing I'm going to do. First thing I'm going to do is I'm going to make sure that the patient is in a recovery position, which means that I'm going to turn them around so that they're lying on the left lateral side. I'm going to make sure that they're not choking back on their tongue. And I'm going to make sure that there is nothing in their mouth that might be suffocating them. So please remember that these are two very different things, and a lot of PLAB questions are twisted like that, right? Now, why I'm telling you, we will come to it later on, and hopefully you will be able to understand the importance of these two particular terms, right? So yeah, here we are. This is a much better example of a normal ECG. So if you pick up any normal ECG, this is what it should look like. So let us assume that here is where we start reading the ECG. You have the P wave, the Q wave, which is a tiny negative reflection. It's not seen here again, but I have another image which you will be able to see. The R wave, which is big positive deflection. The S wave, which is a negative deflection, and then T wave, and then the ECG ends. So all you need to remember is this line joining the S wave and the T wave is called the ST segment, and this is the T wave. For the sake of an MI, that is a myocardial infarction. As a junior doctor in the UK, if you know this much, it should be enough. Can I just ask if I'm going too fast, or is everybody still able to follow? Does anybody have any doubts at all regarding a regular ECG? If you want me to repeat anything at all, please do let me know. I have no problem repeating anything.
I think we haven't gotten any messages on chat box, so I think the speed is very good.
All right, that's brilliant. Brilliant. Okay. So let's go to what exactly is a myocardial infarction, right? So to understand what exactly is a myocardial infarction, we need to understand what exactly is angina as well. So obviously all of you have studied about this. I don't need to go into too much of detail, right? So let's talk about angina first. So angina occurs when there is a reversible damage to the myocytes or the cardiac cells. That is, they're at a lack of oxygen, right? But if you replenish the oxygen to them, they will survive, right? Myocardial infarction itself is irreversible death of the myocytes. That is, it is permanent, irreversible death of the cardiac cells, right? And there are two types of angina and there are two types of myocardial infarctions, right? Angina can either be unstable or stable angina. This isn't too important with regards to today's topic. It is important, but with regards to today's topic, angina is not very important. But again, stable angina is something, for example, you'll hear a lot of patients who will be coming in who are old, right, who have previous heart conditions, and they say, I was doing a little bit of strenuous work. I started having chest pain, a little bit, which was a little dull, and I took some rest. And then after half an hour to 1 hour, it was fine. This is what stable angina is. Stable angina usually occurs when the person is doing a lot of work, but it comes down with rest, right? And it also responds to medications, right? So you may have read about this in MBBS, especially about crystallyl trinitrate, GTN tablets that you put under the tongue for angina, right? You have certain sprays for GTN as well nowadays. So when you give these medications, such as aspirin or GTN, the pain comes down, right? Unstable angina, however, can manifest at any point of time, right? The person does not need to be working. It can manifest even at rest or even very tiny activity. And unstable angina does not exactly respond to medications all the time, right? So these are the two types of anginas. So just go back. Angina is reversible death of the cardiac cells, and an MI or a myocardial infarction is irreversible cells. Now, the main thing that I want to talk to you about today is the myocardial infarction, right? So a myocardial infarction can be of two types depending upon how it is seen on an ECG. Number one is where the ST segment, like I showed you before, the line connecting the S wave, which was the tiny deflection downwards, and the T wave, which is the upward deflection, is elevated on the ECG. That is, it is a little higher than the baseline of the ECG. And a non-ST elevation MI is one where the ECG may appear normal, right? Or the T wave may be reversed, right? So let's just go back and look at what this means. This is the baseline of the ECG. You can see that whatever happens, the ECG is not changing from its baseline. When it is at rest, it does not change from its baseline. So suppose this little line connecting the S and T wave was above the baseline, was right over here. We would call that an ST elevation, and we would think that the patient is having an MI. But patients can also have MIs where their ECGs are completely normal, right? And we call that a non-ST segment elevation MI. So clinically or pathologically, this is what it means. So an ST elevation MI where the ST segment is elevated likely means that the entirety of the myocardium is affected. And a non-ST elevation MI is usually where only a part of the myocardium is affected. Can I just ask if everybody's following till now, if everybody's understood what an ST elevation MI or a non-ST elevation MI is? At any point of time, if you're not understanding anything at all, please do let me know in the box and I will go back and I will address it straight away. So yeah, so if anybody wants me to repeat anything at all, please do let me know. right? So that's what we've talked about. We've talked about an ST elevation MI, and we've talked about a non-ST elevation MI. So you might be wondering what exactly is the difference and why does it matter at all? Both of them are MIs. Both of them are cause death to the cardiac cells, cause irreversible death to the cardiac cells. So why exactly is it important that we know? So it is important that we know because the treatment, I'm so sorry. So the treatment for both of them differs. So the treatment for angina is different. The treatment for ST segment elevation MI is different, and the treatment for non-ST segment elevation MI is very different as well, right? The treatment will come to later. Right. So what exactly are the symptoms of MI? I don't need to teach you guys about this. You guys know me regarding symptoms of myocardial infarction. You know that there's chest pain. You know that the chest pain will radiate either along the jaw or it will go radiate to the shoulder, or it will radiate along the inner border of the left arm, right? Along with that, a patient can also have nausea, sweating, vomiting, right? So these are characteristic telltale signs of a myocardial infarction. Please note that it's not always necessary for a patient to have chest pain when they're having myocardial infarctions. This is just clinically speaking. So when you're interns or if you're already an intern, please note that especially diabetic patients, it's not necessary for them to have chest pain. A lot of them can present with no chest pain at all, right? Especially diabetic patients and especially women. Right? A lot of them present with absolutely no chest pain at all, just some palpitations and difficulty breathing, perhaps, or sweating or vomiting or uneasiness, right? So brilliant. We have a picture over here as to what an elevation looks like, right? So an STEMI is something that you can just abbreviate as STEMI, which is an ST segment elevation MI, right? It's shown over here. So you can see the ST segment is very well demonstrated over here. It is at the baseline of the rest of the ECG, right? However, it is not at the baseline here because the baseline is lower over here. It's actually 2 whole boxes lower, and the baseline is lower. So yeah, the baseline is 2 whole boxes lower than the ST segment, and the baseline over here as well is 2 whole boxes lower. So I think, yeah. So that is what an ST segment elevation looks like. So usually when you see an ST segment elevation and when it is a very high ST segment elevation. So I guess we have a couple of questions on the chat regarding when's the right time to start preparing for PLAB and the CV requirements. Absolutely, we'll definitely get to that at the end. Hopefully, if you guys can stick around or if you guys want to come back also, that's fine. I think we'll just finish this off. But yeah, keep the questions coming, that's fine.
If we are going through it, as in after the last period, when we get finished up with this topic, we'll definitely take all those questions. We have noted it down.
Absolutely, no problem. We can take all the time for the questions.
As soon as possible.
Absolutely. So this is what an ST segment elevation looks like. Can I just ask if everybody's clear as to what an ST segment elevation MI looks like on an ECG? For you an ST segment elevation like this, would you be able to tell it on an ECG? Can I just ask that? Or do you want me to repeat? I know it's a lot of information to process, and usually this topic is something that's studied over 2 or 3 hours. So I realize it's a lot, but if anyone has any questions you want me to go back, I'd be more than happy to do that. Are we good to go? I think we'll skip to the next part. Right, so this is a flowchart which I find very, very important, and all of you will find very important as well, especially when you're in internship. This is a great way to manage patients with chest pain, right? I understand when we're doing our internships, most of the time a patient comes with chest pain, you're going to end up giving them some gastroenteritis or heartburn medications and then let them go. But it is very, very important as a UK junior doctor, for even if the patient is coming in and you know for a fact that the chest pain that they're suffering from is because of heartburn or some gastroenteritis, you have to follow this and you have to go get an ECG. So let's think about it. Yeah. So anybody comes in with a chest pain, what's the first thing you're going to do? The first thing, regardless of anything at all, if the patient is stable, it depends on if the patient is stable or if the patient is unstable, right? If the patient is unstable, when I say unstable, I mean that the patient is collapsing or the patient looks like he's fainting to you, right? You will do airway breathing and circulation, right? So you'll check the airway, which means that there's nothing obstructing the airway. You will also check via your stethoscope as well as via an oximeter if the patient is breathing, that is B of ABC, and C is circulation, where you'll check the pulse and BP. So that's I think a question for another day. Let's talk about stable patients only today. So the patient comes in, he's perfectly stable, but he says, doctor, I'm in a lot of pain and I have chest pain today. The first thing you're going to do is you're going to do an ECG, regardless of what you think it is. Even if he says, I have gastroenteritis, I'm telling you it's gastroenteritis, you will go ahead and do an ECG. It does not matter if you are 100% sure that it's gastroenteritis, you will do an ECG, right? You don't want to miss an MI in any cost at all. Now, suppose you do an ECG and you see an ST elevation. That is an ST elevation MI, you already know that. And the treatment for that we'll discuss later, right? Now, what if you do an ECG and you get a perfectly normal ECG, but the patient is still having chest pain, right? So this is where the question comes. So in this condition, it can either be a non-ST segment elevation MI, right? Or it can be a completely normal ECG at all. But you don't want to miss a non-ST segment elevation MI. So you have to do one more test after the ECG if the ECG is normal. That is, you will go ahead for particular enzymes called cardiac troponin enzymes, and you will try to test this with the help of a blood test, right? So these troponins are just enzymes which are secreted by dying heart tissue, right? So the heart tissue is dying, these enzymes get leaked out into the blood, and you check the blood for these, and if it's raised, it usually means that the patient is having a non-ST segment elevation MI, right? So suppose I find that there is absolutely no ST elevation. I still want to be completely sure, so I'll do cardiac enzymes, right? Followed by the cardiac enzymes, right? Suppose they come raised, right? They're above the normal values. I can go ahead and label it as a non-ST segment elevation MI. However, if my cardiac enzymes are not raised and they're normal, it could be normal, like the patient could be suffering from nothing at all, but the patient could be suffering from angina, right? So this is how I will deal with it. If a patient is suffering from angina, I will give him some painkillers, some GTN, and then schedule him for maybe a cardiology appointment after 2 weeks, right? But if it's STEMI, that is ST segment elevation MI, or non-ST segment elevation MI, then you need to treat them right away, right? So this is an extremely, extremely, extremely important flowchart that you should keep in your mind. And it's going to be very useful as well, especially for someone who's in their third year or fourth year who just doesn't get the entire process of how to approach a patient with any kind of chest pain. This is a very important flowchart, so you can screenshot this, so you're more than allowed to. Brilliant. Right. So I have a question over here. So if everyone can just put in the answers to the question, because I'd like to know what you would do as a doctor. So a 65-year-old woman presents to, so this is an actual PLAB 1 question. So PLAB 1 questions are pretty long. I'm not going to lie, they're usually a paragraph or something. It takes a long time to read them. So this is a very summarized version of PLAB 1 question. So a 65-year-old woman turns up with acute chest pain radiating to the jaw and shoulder, nausea and vomiting since the last 2 hours. On examination, the blood pressure was found to be 180 by 100. And what is the next step in management? So when I say what is the next step in management, I also mean what is the initial step in management. I think I'm getting quite a few answers over here. If everyone is done putting the answers in, I think that will be, so all of you actually are right. You are absolutely right. You will go ahead for an ECG. Yeah, absolutely brilliant. So you will go ahead for an ECG. I know she's in a lot of pain. I know you want to give morphine. I know you want to check AB, you want to check the SpO2, but she's not unstable. It doesn't say anywhere in the question that she's unstable. You don't need to do a troponin right away, right? So you will go ahead for an ECG. Also note that this is how a PLAB question is going to be. I understand the NEET has 4 options, but the PLAB will always have 5 options, right? So it makes it a little trickier. I'm not going to lie. It is a little trickier too, because again, PLAB is mostly eliminating other options. Yeah, so you're absolutely right. The ECG is the right answer. So like I said, there's 3 outcomes. If a patient has chest pain, either it is a ST segment elevation MI, or it is a non-ST segment elevation MI or unstable angina. So the treatments for ST-EMI or non-ST-EMI are discussed later. For unstable angina, like I said, I'll probably schedule a 2-week appointment at the cardiac PD, right, to be seen by a cardiologist. Can I ask if everything is clear at this point? If you have any doubts at all, please do let me know, because I think we only have, 10 or 15 minutes more of this presentation, and I just don't want anyone to be left confused at all. And I don't want to be going too fast either. Can I just ask if I'm pacing it right? If I need to go slower, I need to go.
The pace is absolutely correct. As in everybody is
okay, that's fine.
following
If
the
anyone
question.
needs me to go slower, please do let me know in the chat box.
Yes.
So here we go. So this is pretty important. I know I've written quite a few doses. You don't need to remember the doses so much. Again, actually, no, I've not written a lot of doses. So again, doses are not very important to remember, even when it comes to the PLAB2, PLAB1 or PLAB2, right? You need to remember certain dose of emergency medications, right? Because you can't search them up at that point in time. So for anaphylaxis or MI, you need to remember certain doses, but not all of them. So like I said, like I discussed earlier, the initial step you'll do is very different from the definitive step you'll do, right? So if you see that the patient, you take the ECG for the patient and they have a ST segment elevation, MI, you can do something initially, like initial management, and you can do definitive management. Now, initial management are things you usually do when you are a junior doctor or when you're at this place called a GP clinic. So a GP clinic in the UK is, you can call it a primary care center, where there's a doctor called a general practitioner, right? And he can conduct basic tests and he can give you basic medications, but surgical procedures he will not be able to do. So he will refer you to a tertiary care center. So in the UK, everything, if you're sick, regardless of what happens, you go to the GP first and then you go to the hospital. But you need to understand that a GP can't do surgeries, a GP can't give highly specialized medications and can't do highly specialized blood tests. So these initial management is usually done either in the ambulance or in a GP clinic. Please remember that. And if the question asks, what is the initial step you will do, right? Obviously, first thing is ECG, but if you don't spot ECG, it should be one of these 4. Likewise, if the question tells you that you are in a hospital or you are in a casualty department, right? These 2 are what you will need to do. I will explain them. I promise I'll explain them, right? So these 2 is what you'll have to do. Or if the question asks, what is the definitive step you'll take? These 2 are what is definitive, right? So let's just look at what the initial management is and what definitive management is. So the initial management of, I would say, any kind of MI, even if it is STE, like ST elevation MI or non-ST elevation MI, you will give morphine for the chest pain because the chest pain is a lot, right? So we'll give morphine as a painkiller to aid in maybe reducing the blood pressure if we can. So the reason I've written IV only over there is they might ask you in the options, they might give you what's the initial step that you'll do for reducing the pain, and they might write morphine IV as one of the options and morphine IM is one of the options, right? And the reason you give only morphine is because you're giving quite a lot of anticoagulants here, right? And with anticoagulants, if you end up giving intramuscular injections, the chance of bleeding is higher, right? So we don't want that happening. So whatever injections we end up giving, we usually end up giving them IV. So just a tiny little pointer if you can keep it at the top of your head. So oxygen, we will end up giving if it's less than 92%. Nitrates is nothing but GTN, which is glyceryl trinitrate. You can place it at the bottom of your tongue, right? And aspirin 300 mg is very, very important. If you think that a patient is having chest pain and is having a myocardial infarction, you will give them 300 mg of aspirin. This is done either in the ambulance, this is done either the GP clinic, right? Or if you're a junior doctor somewhere else, right? But if you're in a hospital, right, these are usually not that relevant, but they will give you, if the question says you're in a hospital and what's the most initial step, you can go for one of these 4 if they're in the options, right? So you can remember this with the mnemonic MONA. That's how I remember it. The initial management for an ST-EMI is MONA, and that's how I remember it. Secondly, what is the definitive management for a ST elevation MI? It depends if the patient is presenting within 12 hours of symptoms or after 12 hours of symptoms. If it is within 12 hours of symptoms, you will go in for a minimally invasive surgical procedure called a percutaneous coronary intervention, right? So they will either go for a stent in order to replace the blood flow to the heart, or they will go into the arteries, into the coronary arteries, and they will try to balloon it up, right, in order to replenish the blood flow. You don't need to know all of that. Just remember, it's something called percutaneous coronary intervention. It's a surgical procedure to replenish blood to the heart. And this is only done in an STEMI if the patient presents 12 hours before. So what happens? The patient presents after 12 hours of onset of symptoms. Then you give medications, and these medications are anticoagulants. And the first medication that you give, I know we study a lot about streptokinase as an anticoagulant, but the first medication that you give in the UK is alteplase, right? Which has found to be, it's found to be a lot better than streptokinase, right? And it's found to be more successful as well. So the initial management for an STEMI will be MONA. A definitive management will always be a PCI, a percutaneous coronary intervention, if the patient is presented within 12 hours of onset of symptoms. If the patient has not presented within 12 hours of onset of symptoms, that is, they're presenting later on, then it will be medications, anticoagulants. So please remember, alteplase over streptokinase always in that case, right? Can I just ask if everybody's clear with this, because this will probably be one of the last slides we'll be doing. I'll questions, NST-MI, like non-ST elevation MIs, will probably keep for another day. So can I just ask if anybody has any doubts at this point of time? Anybody at all, you can just leave it on the text box, and I'll be more than happy to answer it.
So we're running a little short of time, so if maybe we could skip to the PLAB2 video or the question answer query session. So that'll be wonderful.
So that's fine. That's fine. That's absolutely fine. Could I just put up this question?
You can wrap up surely, for sure.
Yeah. So I'd just like to give a small question, and this is an actual ECG that they might print for you in the exam. So if somebody could tell me what exactly we have to do over here, right? So when I say next best step, I mean the definitive management. Best equals definitive, right? So if somebody could tell me the answer to this question, you can just put up your answers. Please don't be afraid to just guess the answer and go ahead with it. Do we have any other answers at all? Right. Right. So I'm getting a lot of A's and B's as well. So I think over here, the correct answer will be a PCI, but not to worry at all. I can understand it's a different question because it's framed a little differently. Number one, you need to identify that this is an ST elevation MI. So you can notice the S wave and the T wave. So when it looks like a humpback like that, it usually means there's an ST elevation. So there's an ST elevation in this lead, there's an ST elevation here, and there's an ST elevation here. So even if you see one or two ST elevations, you can assume it's an ST elevation MI. When I say next best step, I can understand that can be a little bit of confusion, but next best step usually means the definitive management of what you would do over here, right? And since the patient is presented within 4 hours, right, and she has an ST elevation MI, the definitive step over here would be a PCI or percutaneous coronary intervention. But I definitely understand why people said A and B. You are not wrong per se. I completely get it, but it'll just take a little bit of time to get a hold of the questions. I feel like maybe the question just confused you, but you're not wrong at all. Thinking from a junior doctor's perspective, it's not wrong at all. So it would not be alteplase or streptokinase. It would not be B or C because the patient's not presenting after 12 hours of the onset of chest pain. So if you would have said A, I completely understand what you're saying. But the answer is D, but I completely understand where you're coming from because the question is a little confusing. So Yeah, so I think we can end it over here. We have another question with the same ECG, but I think we can end it over here. Do you want to, can I just ask the organizer if they want to show the video first to go ahead to answering the questions?
So maybe we can get ahead with the video, like the 8-minute video you had in mind.
Absolutely. So I've just sent it to Rajeshwari. If she can stream it, if that would be okay.
All right.
Yeah, just a second. Just a second. I'm doing
Or if you want me to stream it, that's all right as well. Please show ST elevation once again. Can you just give me 1 second if I could just show this person the ST elevation? That would be great.
Yeah, sure.
Can I ask if everybody can see my screen right now? Yeah, so the ST elevation you can see over here, right? So first of all, in the first lead, if you can see the tiny S wave going here. This is the ST segment. You can see that is elevated compared to the baseline over here. So this is the baseline of the ECG. If I was to track it even with the help of a scale, but I can see that the ST segment is elevated here. Let's forget that because that's a little hard to interpret. Let's go to the next one. You have it very well done over here, right? You have the S wave, which is going down, right? And the T wave over here. And you can see that the ST segment, the line connecting them, is way higher than the baseline. It's one whole big box higher than the baseline, right? So let's skip to V2. In V2, you have an even better representation. You have the S wave over here, the T wave over here, and the line connecting both of them, right, is absolutely way above the baseline. So can I just ask if you're able to see the ST elevation? It's similar in V5 as well. You can see that the baseline is way above ST. But again, I completely understand. This is the first two ECGs you're seeing. I mean, with regards to a PLAB-related ECG, so it can be a little difficult. I get that. Hopefully, you'll be able to do like another session regarding that. But yeah, but if you're able to even point out a little bit, you know, that this is an ST elevation or even one of these, it does not look like a normal ECG, you're more than on the right path, so don't worry about it. So if anyone has any questions or anything, please. So yeah, we could just stream the video. Would you like me to stream the video or would you go ahead and okay.
Hi, my name is Dr. Ahmed. I'm one of the FY2 doctors here at the practice. Can you just confirm your full name and your date of birth for me, please?
Yes, it's Andrew Smith, 15th of March 1960.
Okay, thank you. Right, how can I help?
I've just been asked by my wife to come and have a chat with you about some breathlessness that I've been getting.
Okay, so tell me a bit more about that.
So I've been getting some shortness of breath when I'm walking, usually when I'm going up hills.
Rajeshwari, would you be okay if I streamed it? I think it's getting a little cut off. Right, could you just send me the link on the text box if that's okay with you?
So maybe we could go ahead with the question answers then, since the video, there's some problem with the video then. So
absolutely,
if we
absolutely.
could
so if
carry
everyone
on with the
could,
Q&As.
Yeah, absolutely.
So we'll take it from the top. I think
absolutely.
we've already covered Monica's question on what is MRCP. We'll move on to Tanya's, the part about the second year of internship. Can we go over it again? That's what she has to say. So maybe we could take that part again.
Absolutely, absolutely. So what I'll do is, so can I just look back and I'll just track back and see the question myself. So I have a better idea.
Right.
The part about the second year. Right. Okay. So the UK medical students have 2 years of internship. We need to understand that we only have 1 year of internship. However, it's not like once you go to the UK, you need to repeat the 2 years of internship. They recognize that our 1 year of internship is equivalent to their first year of internship. The second year of internship is where there's a problem. So what you can do is you can Yeah, so like I was saying, what you can do is you can either join an official internship program, which, it's there in the UK, where you can join an actual internship program, and you can only join the second year if you want. Those options are available. I'm not going to do that because I feel like joining a program right now is not something that I would want to. So what I'm going to do is I'm going to work like a junior resident in a hospital in a specialty that I like, right? And I'm going to get a form signed off or a letter signed off by my lead consultants stating that I'm equivalent to someone who has completed their second year of internship in the UK. So once I do that, then I will be able to enter training or post-graduation essentially.
All right, thank you so much, sir. Moving on to Kavya's question, from which year of MBBS should we start preparing for PLAB?
Well, honestly, it depends upon a lot of things. I would say the PLAB is not a very labor intensive or a study intensive exam to give. The PLAB one is relatively easy to give, right? If you put in the work, you will pass. There's no doubt about it, but you have to put in the work, right? It is easy, but it's not a cakewalk. So I would say there's a lot of, so if you're in internship right now, right, I would say right now would be an ideal time. You can definitely get in touch with me to see how you could book PLAB 1 because PLAB 1 places are in short supply. If you're in third or fourth year, what I would advise you to do is I would advise you to wait and look at how the circumstances are, because a PLAB is going to be replaced by another exam called the UK MLA. So the only difference between PLAB and UK MLA is that, again, UK MLA is also 2 steps. All the experts right now are saying it will be the same as PLAB, but the difference is this exam, PLAB is only given by international medical graduates such as ourselves. UK MLA will be given by both the UK medical graduates as well as you guys. So think about it as something like the next, or what the NMC is trying to do with the next, right? So even if someone studies in the Philippines or in Hong Kong or in China, whatever, they will have to come back and give the next, but so will medical students over here, right? So think about it like that.
All right, sir. Thank you so much. That was really insightful. We'll move on to Monica's question. After 3 years of training, do we have to give MRCP if we don't want super specialty?
Not at all, not at all. So you won't become a consultant, perhaps. You'll be at a certain level known as a registrar, right? So let's compare. So consultant is someone who is at the top of their game. There's absolutely nothing higher than a consultant. So you can equate somebody. You can't equate it, but I equate a UK consultant as somebody as having done, somebody who's done MD or MS, and then they've also done a super specialty and they've done a DNB or a DM or whatever, right? So because that's the amount of years that goes into it, right? But there are a lot of people who don't go into super specialty at all, right? Because number one, sometimes it's a little competitive and sometimes it's just not, so if you go into a training program, the pay is lower. But if you just get out of, PG or core training, right? And you work like jobs here and there, it's a lot higher paying compared to being in a training program, right? So you don't have, you don't have to give MRCP per se, but usually some educational institutions will ask you to take the MRCP in the first or the second year, maybe in the second year onwards, if you're doing internal medicine training, right? But again, it's not, if you're actually in the UK, I've heard from people who are in the UK, if you're in the UK system, the MRCP isn't very hard. If you're approaching it from the outside, it may be a little harder just because you're not used to the system. That's it.
All right, thank you so much. We have another similar question. Do you need to give PLAB before MRCP or can one give it directly?
Yeah, so you can give MRCP directly and you can get GMC registration straight away with MRCP, right? But you need to understand that the MRCP is 3 steps, 2 theory steps and 1 practical step. And the MRCP is, I would say, the PLAB on steroids, right? That's how I would compare it to. The MRCP is it's a super specialty level exam. It's not a PG level exam. It's an exam you write to get into super specialty. It's not competitive or anything. You just need to pass it, right? But again, you need to understand that there are a lot of people in their PGs, even post PGs, who give MRCP. A lot of them make it, some of them don't. So you need to look at it from that perspective. You can absolutely, there's no rules that you cannot give MRCP, right? But understand that it's 3 steps and it takes time, right? But you can absolutely give MRCP before the PLAB if you feel like that is your experience and you're experienced enough to deal with it. 100% go for it, right? I went for the PLAB because at my level, at that point of time, it was more relevant. If I was to start with the UK process, maybe if I'd already been working in India for 3 years after graduation, I probably would lean more towards the MRCP. But fresh out of internship, I wanted to give the PLAB.
All right, so thank you. Then Shravya has two questions. Firstly, when is the right time to start preparing for PLAB? And secondly, what are the materials to be used? So I think we've covered the right time earlier.
Yeah.
So if you could share some insight into what materials need to be used for PLAB.
Again, right time, if you're in third or fourth year, don't worry about it. See how it goes. So one more thing I'd like to add is the PLAB is an exam the PLAB 1 at least is not an exam that's not very hard to study for. I studied maybe a maximum of, I would say, I started with 2 to 3 hours of study for the first month. And then the maximum I even reached was maybe 4 to 5 hours a day. And that was in the last month. And I gave maybe 3 to 4 months for preparation. I was very relaxed during my prep and I scored pretty well in my PLAB 1. So I would say it's an exam that you can actually combine with the preparation of another exam, right? So if you have something, so I would say since for the people in third year and fourth year, since the future of the PLAB is not very clear right now, you will have a better answer by the end of this year, trust me, regarding the PLAB and whether it's going to be replaced by the UKMLA, how the UKMLA is going to be like. But keeping the NEET in mind and preparing for the NEET, right? That is something that you can prepare for at this point of time, right? I have a lot of friends who've given the NEET, who got a rank in the NEET, also clear the PLAB 1, PLAB 2. So they have options of both. I didn't have that because I only gave the NEET in my internship, but the subsequent NEET I didn't end up giving, right? So that's an option I think a lot of people would want to have. You want to have like options. So, and the NEET is something that you can prepare for. The next is something that you can prepare for at this point of time as well. The next, obviously, I'm not sure, but the NEET you obviously will and can prepare for. The MLE is similar. You can prepare for the MLE because you can start preparing for the MLE right now. And yeah, that's about it. And if you're prepped for the MLE or NEET, the PLAB 1 at least should be easy. PLAB 2 is the only hurdle. But regarding PLAB 2, they like the study resources are more than okay. Regarding the study resources for PLAB 1, you have certain question banks. It's very similar to Marrow, honestly speaking. So you have a question bank, which I call PLABable, right? It's called PLABable. And this question bank, I would say, is a Bible for PLAB 1 prep, right? It has around 5,000 to 6,000 questions in it, spread across 19 topics. And this usually, if you want a 3-month subscription, I think it's anywhere between 3,000 to 6,000 rupees, right? For a 3 to 5 month subscription. I'm not exactly sure, but it should not exceed more than 5,000 to 6,000 rupees for the question bank. Along with the question bank, I needed online notes as well. So there's something called PLAB 1 keys for that. So I subscribed to that as well. That was an additional 4,000 to 5,000 rupees for 4 to 5 months, right? And nowadays, people are subscribing to another question bank called Med Revisions, which is again 3,000 rupees for 3 months, right? I had subscribed to Med Revision, but I didn't use it too much. So a question bank and a note service is what I used, right? The question bank was called PLABable, and the note service was called PLAB 1 keys, and they're still first things that people use for their preparation right now. And for PLAB 2, it's a little different because PLAB 2 is given in the UK, right? PLAB 1 you can take around the world. PLAB 2 is given in the UK and only in the UK and only in Manchester, actually. There's only 2 centers in Manchester, both opposite to each other, which take the test. And because of that, there are academies for PLAB 2, right? These academies tend to be a little more expensive. So these academies usually run a 12 to 15-day course. You can either go to the UK and take it on your own, or you can take it online with the help of live classes. I had gone over there and taken it on my own, right? Because I felt like for me, I needed the practice person to person, but I know lots and lots of people who have taken the online live classes where they see the class going on as it's happening, and they've gone ahead and passed the exam as well with flying colors. And these academies can cost usually around 400, anywhere between 400 to 500 pounds for the 14-day course. I know it seems like a little expensive. It is, honestly. There are people who choose to do it without any academy as well, with just online materials. I wouldn't. But since you want to clear this exam as soon as possible, and the guidance that they give you is very, it's not just limited to the 12 days. You can stay in the academy, you find a study partner, right? They have mannequins available for you to practice on, for example, PLS mannequins, examination mannequins, and all of that. So all of that support entails the 400 to 500 pounds. And some of them also are very gracious enough. So if you don't make the exam, you can take the course again. So yeah, so that's how much it would cost. And these are the study materials regarding the same. But yeah, that should be it.
All right, sir. I hope everyone's taking notes because we won't get these golden words of wisdom back. So this is
No, please,
very helpful.
no. If anyone wants to contact me regarding the same, I'm more than happy to help as well.
All right. So let's move on. We have another question asking, what are the CV requirements for PLAB1?
You don't need any CV requirements just to write PLAB1. You just need a valid English test, and you should have completed your final year exam. That's about it, right? If you're asking for what are the CV requirements for the UK system, I would say there are different. That's an entirely different conversation. So they grade you on different things, right? So they grade you on teaching, leadership qualities, maybe any papers you might have written, any research papers, and that's pretty much it. And any, maybe if you've done well in college, you've got like a first or second rank, or you've got distinction or something, but these are all minor points. I want you to know that a lot of people who go to the UK with the PLAB route don't really have a lot of these in their CV. Their CVs are most of the times blank. What I would suggest is I tell everyone is, as soon as, if you're looking towards the UK, don't have any gaps. I would say don't take any gaps in your internship. You can take like maybe a month gap or something, that's fine. Don't take any gaps in your internship. As soon as internship ends, start working. That was a mistake that I made, because I started having a clinical gap of at least like 6 to 8 months, just because of COVID, because I didn't work and I was preparing for my exam. Because people in the UK don't understand the concept of gap years of just for an exam, right? People take gap years for other reasons like vacations and all of that. But for an exam like PLAB1, they usually prepare when they're working, right? So for the UK, for also all of these things like research, publications, and lead, if you can get them done in UG, well and fine. But I don't want you to worry about it too much, because I didn't have any of that. I still don't have a lot of those, right? So don't worry about it. Just experience should be fine.
All right, sir. Moving ahead, Namami has a question. In order to know the UK system better, is it better to join FY1 as compared to FY2 after completing internship in India?
Oh, that's a great question. That's actually a very good question. It all depends upon you. I would say you can join at FY2. If you're done with your FY1, you can join at FY2. People do find it overwhelming. I'm not going to lie, but people also find it overwhelming when they join PG in India, right? You're going to find it overwhelming regardless when you step to the next stage, right? Give it 4 to 5 months and you will be fine in an FY2 position. I would only recommend an FY1 position to someone who's had a very long clinical gap, probably like maybe 5 to 10 years. A lot of people after MBBS don't really like go ahead and practice. They do tend to have a clinical gap, or maybe they have other priorities. So maybe I would recommend FY1 to somebody like that. But I know a lot of people like that who joined FY2 and have learned the tricks of the trade within 6 months, right? And another person that I would advise FY1 for is maybe if you haven't done internship at all. So that's also a possibility for you to do both the years of internship in the UK without having done internship in India. But that's a little bit of a complicated system. But if you've done internship in India, you can go ahead and you can start with an FY2 level position.
Okay, so am I audible?
Yeah, please go ahead.
Yeah, so there is this one more question which people are asking that.
Recording in progress.
Okay, so Swaraj is asking, can we opt for CT only, or do we have to complete ST program too? That is total of 6 to 9 years.
Right. So no, not at all. You can finish off CT and just keep working at that level. There are lots of jobs at that level where you complete CT, right? And you can stay at that level as well. And it's not that you will, a lot of people think that, you need to become, it's the same in India, right? Like you don't need to do a super specialty per se. You can either stop at that level and then you can, so you remain at the level of the registrar, right? So a registrar is somebody that I would say is, if I had to equate it to Indian terms, a senior resident, right? So a senior resident is somebody who's completed their PG. A registrar is some, right? in the UK. So you would remain at that level, but there are lots of jobs available at that level, and you will be definitely paid well. And there are lots of options to earn more as well and keep increasing your pay over the years. It's not necessary that you have to go for specialty training. I know a lot of people who are still stuck at that's like right out of CT, but you don't need to go ahead. Like I know people who don't intend to do any kind of specialty training at all. So yeah.
All right, sir. I hope that answers your question, Swaraj. So the next question is coming from Shreya. Sir, what kind of residencies can we expect? And our surgical residency is extremely hard to get in.
Right. So again, great question. I would say everything is competitive nowadays. Like everything's getting competitive. Maybe 2 years ago, it was really easy. Everything's getting competitive, but I would say just compared to the rates alone, if I had to compare it with the US system, so I'm assuming that's what this person means when they use the term residencies. I would say surgery is not as hard to get in the UK as it is in the US. Whenever I ask anybody who is a consultant right now or who is doing their training, they're like, nothing is impossible because you're competing at the same level as the UK graduates. They're not given any preference, right? So if you work on your CV enough, right, if you give enough time to it, if you know everything that they're looking for and finish those things, there's no reason why you shouldn't get a surgical position, because it's the US is rather upfront about it. They tell you that you're not at a preference because you're in IMG, but in the UK, there's nothing like that. You are just absolutely at the same level as someone who is a naturalized British citizen or a British graduate. So I would say so the way we judge how competitive it is in the UK is via competition ratios, right? So competition ratio, the higher it is, it's a whole number. It's not a whole number. It's a number. The higher it is, the more the competition it is. So the way we get this is we take the total number of applicants for a particular specialty in a year, divided by the total number of actual seats there are, right? So the higher it is, the higher the competition, right? So for internal medicine last year, the competition ratio was 2, which means for every 2 people that applied, there was 1 position open, right? So that is actually a very good competition ratio, right? That's a very, very good competition ratio. Surgery last year was 3.7 or 3.8. That is for every 3.8 participants. Every 3.8 participants have to compete for 1 post, essentially. That's what it means. So that's a little on the higher side, but it's not as high as a lot of other, like the highest competing ratios, competition ratio in the UK would be probably for radiology, ophthalmology, and those, say, but it's high for surgery, but it's not impossible. I would say ophthalmology is close to almost impossible, or US level like hard. But if you work for it, there's no reason why you shouldn't get it. Honestly, if you take time off, work on it, once you're working in the UK during that FY2 year, you take the time off, do your research, do everything that's needed. There's no reason why you wouldn't get the job.
Thank you so much, sir. So the next question to you is, sir, did you go for any sort of research electives before your PLAB journey?
No, actually. So I understand that electives so research electives is a very US-based term towards the US Assembly. The way we call it, we don't call it a research elective. Okay, let's not call it a research elective. Let me talk about observerships, right? So how observerships are in the US. In the UK, they're getting a little more popular. You don't have to pay for these. Some hospitals do take money for them, but it's a period of observership where you just observe the doctor. And nowadays they're gaining prominence because hospitals prefer someone who's have a couple of hospitals, not all of them. So a couple of hospitals prefer someone who has had some exposure to the NHS system, right? So you can contact any consultant and they'd be more than happy to let you on. You don't have to pay for an attachment. If any hospital is asking you to pay for an attachment, I would say if it's anything above 100, 200 pounds for 6 weeks, say no right away. I actually had an attachment planned. I wasn't able to do the attachment because my exam got postponed. But attachments, they're not that important. Regarding research itself, I did not have any research when I got out of internship, anything at all, like not one. I still don't have any research projects going on. I have a couple of publications in PubMed index journals. This isn't research. These are publications in the sense that they're letters to the editors. So I needed something that was a PubMed publication. And since I was not working at the time, it was difficult for me to do research. So letters to the editor are a form of publication which are a lot easier to do and give you a name on the PubMed ID. But all of these things, if you're still in UG, you don't need to worry. If you get chance
Recording
to
stopped.
if you do get chances to do research, do look ahead, look towards your consultants, be like, listen, I will do absolutely anything. I'll do the dirty work. I'll go ahead, do the paperwork. Just put me as an author. Right? Go ahead and do that. I would encourage you to go ahead and do that. Because that's the best way. Once you get out of college, it's a little difficult to find anyone who would let you in on their research.
All right, sir. So next question to you is, what is the syllabus for PLAB 1?
Right. So PLAB 1 is, there's 19 topics, all clinical, right? In the sense that all clinical, as in obviously it has topics such as anatomy and everything, but it'll be very clinical related questions. So it might be something along the lines of a patient comes in and has slashed his wrist, right? And now the patient can't flex his distal interphalangeal joint or whatever in his, he can't flex his DIP. So you need to find out what exactly what tendon it is that's causing that. So it's a very clinical based questions like that. So there are 19 subjects, all subjects that we've studied, such as anatomy, cardiology, neurology, urology, nephrology, all of those things. So there's 19 topics spread across like that. All clinical, all things you've studied, all things you've definitely read of at least once in your life, or you've at least heard of. Should not take more than 3 to 4 months for you to go through the whole thing. Yeah.
And sir, are there any scholarship exams that can help us with the PLAB?
Can I just ask for some more clarity regarding what kind of scholarship exams are you talking about?
Kavya, if you're there on the chat, can you please unmute yourself and answer?
So with regards to if you've actually, I don't know if this person has got a scholarship or.
I guess she's asking for like if any scholarship can help them.
You don't need to pay for when you're training in the UK. So that's an important thing. You don't need to pay for when you get accepted into IMT, they're going to pay you. You're working for them. So the only thing you have to pay for is the exams, the preparation fees. But as soon as you start working in the UK, your first month in the UK, you're going to be earning at least, obviously things are expensive in the UK. I'm not going to lie, the standard of living is a little higher. So, but you earn a good amount of money. You earn anywhere, if you start an FY2 job, you earn anywhere between 2,200 to 2,800 pounds a month. I would say, obviously it depends. This can be a lot. This can be very little, depending upon where you're staying. If you're staying in London, which is the capital, I would say it's very difficult to save anything at all. If you're living somewhere like towards the town or towards the countryside, maybe up north in Scotland or in Wales, it's a little better to save and you can live a comfortable life. If you're single, you can definitely live a comfortable life. If you're trying to support a family, it becomes a little more complicated, but there's always do overnight shift. A hospital will be looking for doctors for shifts for like maybe one night or something on the weekends. So there's always ways to earn money.
All right, so thank you so much.
No, don't worry.
Yeah. So the next question is there? Yeah, you answered this question about the electives.
Right.
Okay. So the next question to you is from Shravya. When do we start earning once we have to get into the college, and how much is the minimum stipend given? Also, how much is the college fee?
Right. So like I said, there's nothing like a college. I'm so sorry I'm moving around. Just give me 1 second. There's nothing like a college or anything of the sort. It's not an educational program. You're going to be working for them and you're going to be working through the system. You don't have to pay for anything except for the exam fees, right? So if I'm I'm going to pay for PLAB 1, I'm good. So far, I'll tell you what costs I've had. I've paid for my IELTS. I've paid for my PLAB 1. I paid for my PLAB 2. I've paid for all of the study resources for that. I paid for my visa to go to the UK. I've paid for my flight tickets to go to the UK. I've paid for my PLAB 1, PLAB 2, like I said, but I haven't, once I join training or even once I join a job, I don't have to pay them anything at all. You don't pay them anything at all. Like I said, the previous slide that I had regarding the costs of the entire process, I would say after you clear PLAB 2, if you get a job, it takes a little while to get a job after clearing PLAB 2, maybe like 4 to 6 months. But once you get a job, it should not take you more than, you'll probably need your family support for the first month because you're not getting paid. But after the first 2 months, you can live very well on your own. unless, because healthcare is free, so you don't really need any emergency savings or anything of the sort. So yeah, there's no stipend is your pay. You're going to be getting paid, like the starting salary after PLAB 2 is what this person is asking, I think. It's probably 2,200, 2,100 to 2,800 pounds a month. So it depends on where you live. That can be either a lot or very little. It depends on how you live, right? But I would say it's definitely like upper middle class in the UK. Like that's what the salary is.
Sir, I have one question from my side.
Yeah.
So what made you actually select that you want to go for PLAB and not for MLE and for next or NEET PG here in India?
Okay, so I didn't want to do the MLE because I was too lazy. I'm going to be honest with you. Like I could not, I'm not a type A personality. I knew that the gap year was going to be a very psychologically challenging experience for me. Along with COVID, that became, twofold. So I knew that it was going to be a very difficult year, and I could not see myself going through. I definitely, I'm not going to lie. If I have to choose the best medical system right now, just for training and financially rewarding wise, I would choose the MLE. If I was a type A personality, I would have definitely gone for the MLE. If I had perhaps somebody who had already done it, somebody that I knew of who could guide me through it, I probably would have gone for the MLE, right? Because the financial reward at the end of it is incredible, right? Even though you train for more hours and the hours are crazy, you do train pretty well. And the lifestyle is incredible for a doctor over there. I initially did want to do the NEET. I wanted to do the NEET, and honestly, even 4 months before my internship ended, I wanted to do the NEET the next year because I'd written the NEET in my internship, and I was pretty satisfied because I got at least a qualification score. So I was like, I can do this next year with the right amount of prep. But I have quite a few relatives in the UK, right? So it initially started off as family pressure, but later on, once I thought about it, I'm not somebody who's going to, I feel like I've done my bit of hard work in MBBS, right? And I don't want it. That 1 year seemed very psychologically challenging. And I also wanted to be financially independent. That is very important for me. Like I thought I'd be financially independent at 23 when I used to be younger, right? But in MBBS, that's a little impossible. But I want to be financially independent as soon as possible, right? And I know that in India, to be financially independent when doing PG, you need to have an incredible rank to be in a government college. And I wasn't sure if I could do that, right? And with NEET changing its guidelines, with the introduction of deemed colleges, which started appearing during my time, that is what was happening. And obviously, everyone has their preferences, but I feel like I kind of settled into the UK thing. And then I went over there, I saw the system as well, and I really, really liked the system. So yeah, every system has its faults. Yeah, you're going to find a lot of changes, obviously, when you go to the UK. I know a lot of people who are homesick over there, all of those things. They experience a lot of difficulties as well. But I feel like everything has its pros and cons, and you need to decide. There's no one best medical system, right? So you need to decide what's tailor-made for you.
Thank you so much, sir.
Thank you, sir. That was really insightful. We have just one last question
Absolutely.
for you
Please
from Suraj's side. He is asking us that can we complete only CT program and come back to work in India? Come back to India and work here. Yeah.
If you complete only your CT, it will be a little difficult for. I know people who've completed the ST and they've come back over here, and they're consultants in the top hospitals. Like I know a lot of people who have done that. I know at least 4 or 5 people. In fact, one of the radiologists that I'd gone to for one of I think my mom needed a CT scan. So he had completed his entire thing. Radiology is a little shorter in the UK. It's only 5 years, the entire thing, right? The entire program, including super specialty, is just 5 years. So he completed the entire thing and he come back. So I know a lot of people like that who've come back. But to finish CT and come back to India, I would say I'm not. Obviously, you wouldn't be preferred in like a teaching hospital or a government medical college or a government hospital. It should be private, medical centers that usually do it. I'm not too sure. I wouldn't say they would be too willing to hire you, right? But again, I don't know about that. But a lot of people don't do that. They usually complete the whole thing, or they stay in the UK. And usually, when you complete those many years in the UK, it becomes convenient for you to stay over there. Yeah.
All right, sir. Thank you so much for sparing
I
your
think
time.
there's one more question. Can I just
yeah, for sure.
regarding someone who has their PLAB 1 this August. I think Prachi.
Excuse me, sir.
Yeah.
So I wanted to ask that I don't have any publications or anything. Like I'm just gonna enter my internship. Like I'm yet to give my final year practical exams, and so I don't have any publications or anything of that sort. So will that be any kind of disadvantage for me?
Not at all. I know a very good friend of mine. I didn't have any publications right as I was getting into internship. I have a very good friend of mine, a very close friend of mine, who passed his PLAB 2 months before me. He had publications only because I chose to do a couple of publications and I put his name on it just because he was a close friend of mine. He did not put it on his job CV though. Like he did not put it because he was just trying it out. And the second job that he applied for, he ended up getting. So it's not necessary that you absolutely need publications. If you can get into it, well and good. But otherwise, you really don't need publications at this point of time. You will figure it out once you start working in the UK or once you go down that route. Like there'll be a lot of people who will be willing to help you. But just once you're entering internship, when I was entering internship, I didn't even know I wanted to do the PLAB, right? I didn't have any publications, anything at all. So don't worry about it. I think, yeah, I hope that answers your question.
Yes, thank you, sir. So one more question, sorry.
Yeah.
Sir, like I have heard it's kind of rare to India. It's feasible that we prepare a proper CV in India. It's like audits and everything. We prepare in advance in India and then we move to UK with everything which is required instead of going there and preparing everything from scratch.
The problem with that is, okay, so if you're asking with audit's point of view, so audit is something in which you, just for everyone else, and audit is something that they look at in the UK as well. They want you to understand what it is. It's a process in which you look at something that's going on in a hospital, right? You observe whether that process is effective or not, and you suggest changes to it. So for example, if a patient is coming in and we are prescribing them, so this is an audit idea that I had, obviously anyone's free to take it. If a patient is coming in and we're giving them antibiotics, right? I'm observing how many doctors in that particular center are actually prescribing any kind of proton pump inhibitors with the antibiotics, so any kind of pantoprazole, right? So I'll observe the percentage, right? And I will see if it's a low percentage, I will suggest changes, and I will put up guidelines later on stating that, okay, everybody who's prescribing antibiotics has to prescribe a proton pump inhibitor after ruling out any kind of allergies. And then I'll observe again for another like 3 or 6 months. And I will find out if doctors are sticking to that and if patients are having any complaints later on. So that's what an audit is. Think of it as a quality improvement protocol. That's what it is. It's called a QIP. Right. So no, the thing is, audits are not such a big thing in India. You're not going to find a lot of places doing audits. And even if they do audits, they're not going to involve medical students or interns in audits. It's usually private medical centers, highly specialized private medical centers, which go in for audits. Obviously, government medical colleges go in for audits as well. But it's not such a big thing in India. And the thing is, if you're doing an audit in India, you'll have to stick to the Indian guidelines. And there's no such thing as Indian guidelines. Right? Nobody has guidelines in India. Everyone practices from different guidelines from all around the world. Right? So a lot of people say that audits in the UK are more valuable, and you'll have a better idea of doing it as well. So I haven't done an audit for that reason. I've had opportunities to, but I would prefer to go over there and do an audit. Right? But if you can do one over here, there's no harm in doing it. You can go ahead and do it. Right? But just because you don't have it is not going to be an issue. So I've just got Prachi's question. I think it was a direct message to me. That's why nobody could say it. See it. She just says she has PLAB on this August, and everyone says that PLABable isn't enough. I haven't done a whole lot of preparation here, but I have a subscription of Med Revision and PLABable both. I'm reading notes at the time and planning to solve questions next. Would solving them once be enough? Right. You have a lot of time till August, so give most of your time to PLABable. Don't give a lot of time to med revisions. Like, keep it as your secondary source of information. But I solved the questions of PLABit twice, right? Solving them once, I would say you just are not going to remember, right? So aim to solve them twice at least. And the mocks you give in PLABit are again a revision. So you can give them once and then you can give them mocks.
So are we done with
So,
the questions? I'm sorry, is somebody asking something?
sorry to interrupt everybody. Any sort of preparation platform like Marrow and all, like proper they teach the concepts and everything like a proper teacher, and we get to learn from that teacher. Is there any sort of like coaching program?
Flap one, I wouldn't say
Uh,
you need it. You don't need it. Trust me, you don't. It's a
okay.
very easy exam if you put in the work for it. You don't need anybody with any kind of videos for Flap one. Trust me when I tell you that. Right? You need the notes and the questions. That's it. You do not need any kind of coaching. There are a lot of coaching centers available, but I would say just for you to save your own money, do not go for it. Just get what everybody else is doing, right? Because it's not a competitive exam. You don't need to outscore everyone else. You need to get the passing mark. That's it.
Thank you so much.
No worry.
For further queries, how can we contact you?
I think I think Rajeshwari has my contact details. You can either share my number or my Instagram handle or my email as well. I think all three should be fine. I don't mind. You can just leave me a text anywhere at all, and hopefully I'll be able to answer that.
We'll look into that, sir. Thank you so much.
No problem at all.
All right, sir. Thank you so much for coming and sharing your valuable words with everybody who joined in today. I think they learned a lot from you today and how to approach PLAB. And you also went into the details of some of the questions. So that was like really unique. And we weren't, it was like a really big deal for all of us to actually listen to you and gain insight into how to approach PLAB. So thank you so much, sir, for joining us today. And it was our pleasure to host you. And we look forward to more interactions with you in the future as well. And we would like to wish you all the best for your endeavors. Thank you so much, sir.
Thank you so much for your time. I really appreciate it. You guys are great. Yeah, you guys are incredible. Go ahead, keep doing the work you're doing. You guys are great.
Thank you so much, sir. Thank you. Good night.